This is the second part about nursing management for the child who has cancer. So we're talking about taking care of the side effects that occur as a result of the therapeutic modalities the child must endure. Stomatitis is quite common, and what it is damage to the mucosa that's in the mouth, and they can develop ulcers, they can get herpetic lesions, or they can get a fungal infection, and we call that thrush. So it's very important that your assessment includes a very good inspection of the mouth. So you need to use your pen light, and you're going to use a tongue blade so that you can really get a look. For your younger kids, this is going to be quite challenging because you have to keep in mind that they have very low platelets and you don't want to cause them to bleed. We want to promote oral hygiene, so once again, using that soft toothbrush. And then the mouthwash, we have a magic mouthwash that has an anesthetic along with an antibacterial. But you have to be careful with this because that anesthetic, when it's swallowed, takes their gag reflex away. Paradex is one of the brands that we use for the mouthwash, and it's the non-stingy type. We can also put the Paradex on a pacifier for our younger kids. For thrush, we are going to administer nystatin, and it's usually ordered as either a swish and spit or a swish and swallow. And the swish and swallow is because when you have thrush on the buccal mucosa, this kid is also swallowing it, and so it goes all the way down their throat. So if it looks like they do not have any going down the throat, that child will swish and spit. So you just have them swish it around in their mouth, maybe even gargle a little bit, and then spit it into an emesis basin. Here's a picture of what thrush looks like. So they're little white plaques, and you can't scrape them away from the buccal mucosa. Children undergoing treatment for cancer have a nutrition deficit. Our goal is to prevent weight loss and to promote healing at the same time. It's difficult for a kid to eat when they have nausea and vomiting or when their mouth is full of ulcers. And then put that along with their normal developmental milestones, that picky toddler that doesn't want to eat anything, or the adolescent who is, no thanks, I'm not going to eat, I'm going to wait till my mom and dad come in and bring in the In-N-Out burger. But mom and dad forgot In-N-Out burger, so therefore they are not eating at all. There may be some instances where we're going to insert either an NG or an NJ tube and give them feedings throughout the night. And then others will require TPN or PPN with lipids. As a result of rapid breakdown of tumor cells, the children can develop tumor lysis syndrome. As the tumor is disintegrating, it's releasing a lot of phosphorus and potassium, so we have to monitor that potassium level. There's a potential for renal damage to occur. What we do for this is hydration, and these children will get double maintenance. So if their typical is 88 mLs per hour, then we're going to be giving them 176 mLs per hour. We may be administering bicarb to neutralize it, but when we give them this hydration, we are not giving them extra potassium. These tumor cells also raise the uric acid level as the cells break down, and so you'll be giving allopurinol 2 or 3 times per day. You should be very familiar with the side effect of alopecia, same thing that happens in adults. It is very drug specific, and what's really unusual is that people who have straight hair that have chemo and lose their hair ends up coming in curly. I'm not sure why that happens. But losing the hair can be very traumatic. There's a lot of things you can do. Number one, help them with their hygiene. When it comes out in clumps, and so their hair is like a rat's nest. Comb their hair for them. Ask them if you can cut it. When you see hair on their pillowcase, change the pillowcase. Gather up the hair. Don't make them see it. Don't let a kid go down the hall with a big wad of hair sticking out. Make them look good. We can give them hats, wigs, and scarves. Child Life is very good at helping out with this, but there's no reason you can't do it. Some of the children will opt to have their head shaved. They don't want to go through it where they're going to see their hair on the pillowcase, so they'll say, just buzz it off, especially the boys. The psychosocial needs of the family and the child are huge. Remember, the initial diagnosis, they're in shock. They don't know what end is up. They're grieving. They feel guilty that, oh my God, if I would have just noticed these signs and symptoms earlier, it wouldn't be so bad. They're scared to death that they're going to lose their child. And they might even be blaming one another for not bringing the child in. I told you so type things. So we use an age-appropriate approach, as we do with everything, when we're going to explain what's wrong with them. So you need to be very creative. How fearful they are, how stressed they are, will vary according to the age. The younger kids, they have no idea what cancer is. They will never know what cancer is. All they know is everything we're doing to them makes them feel awful. Common issues that come up is dealing with the painful procedures. And we have come a long way in that we will use conscious sedation in a heartbeat. If we're going to do something that's going to be painful, we're giving them conscious sedation as they go through it. The children are going to be in the hospital for a long time, so they're going to be separated from their family and their peers. Remember, these kids aren't driving. They're not old enough. We're not even letting young kids come onto the HEMONC floor. We have to balance their playtime with their time for rest. The children learn over time what they can and cannot tolerate. Other common issues are the altered body image. When we give them steroids, they become cushingoid. So remember what that is, that big moon face. The rest of them is really thin, but they look in the mirror and they see that round face. They don't like it. There's limb loss that affects their body image. They need privacy. Some of them feel so awful, they don't want any curtains open. They don't want to be reminded of what they're missing outside. They're going to become introverted. They don't want to share their feelings. So it's our job to try and get those feelings out of them. Some of the children may have depression, and we'll go ahead and we'll treat that. Here's what a little child looks like who's been getting steroids. You see how chubby? That's all from the steroid. So once again, the nursing interventions, body image, hats, wigs, and scarves. Let them wear their own clothes. Paint their nails. You know, the girls love to do that. Provide privacy and respect the attempts for them to maintain their privacy as much as possible, and privacy is spelled wrong here. Provide the emotional support to everybody. When these kids start getting sick, it's palpable, the sadness on the unit. And we have to acknowledge that with one another. There's going to be some times that you have tears in your eyes. You don't want to break down and cry in the room, but you can come outside and break down in front of your peers and get the support yourself. Recognize signs and symptoms of depression in these kids. Let's get a counselor in there to help this child. And then some of the kids get really, really bored, while others feel so awful they could care less what's going on and they don't want to do anything. And here's a lovely drawing from a child. And you see, these children are not their cancers. For those of you who may have been at CHOC and you went on the HEMONC floor, I'm sure you saw that. And especially if you went to the outpatient infusion center. So when you're helping the families, they are dealing with a life-threatening long-term illness. The child is, and the parents are right at the bedside. These parents still have a job. They may have other children. They still have a house to maintain, and they're very torn between, should I stay at the hospital or do I need to go home and take care of the rest of my family? The siblings have needs. They feel guilty. Oh, gee, if I wasn't so mean to Joey, he never would have been sick, thinking that they were the cause. Others may feel jealous because little Joey is getting all the parents' attention and aunties and uncles and grandparents. They miss their sibling. They miss their parents. They miss the family that used to be before this child got sick. And then, of course, we have their spiritual needs, cultural needs, and their diversity needs. There are long-term issues related to psychosocial, and that may be their reproductive system. Wow, I have testicular cancer and they had to remove one of my testicles. Does this mean that I'm not going to be able to have children when I grow up? The same thing when we have ovarian cancer. When a child is undergoing chemotherapy, there's a maximum dose that anybody can get in their lifetime. And so that's when we give up on chemotherapy. We didn't get the response, and we've completely maxed out all the drugs. And cancers can recur. there can be a relapse, and there can be a metastasis that comes back years later. It's always sad when the kid comes in for that 5-year checkup or that 10-year checkup for leukemia, and they do the blood count and they look up and it's back. Very sad situation. So this ends the nursing management section.